Good evening, everyone. I am honored to welcome you to this webinar, but also saddened by the circumstances that have brought us here. My name is Tariqul Islam, and I am the president of Rise for Rohingya, which is a nonprofit campaign committed to positively impacting the Rohingya refugees by spreading awareness within our local and global communities. I want to start by thanking all those who have made this possible. Rise for Rohingya would not have formed without the support from NYU President Emeritus John Sexton. John has been our mentor and supporter at the same time without expecting any recognition in return. I would also like to thank my team members, Jaheen, Ramim, Mohammed, Kedar, Shafat, Ryan, Catherine, Rashid, Cheyenne, Ewan, Tasman, Dr. Tondra, and Dr. Halim. They deserve a round of applause for putting up with me on a daily basis. At an average density of more than 103,600 people per square mile, the Rohingya camps have 4 times the population density of New York City and 40 times the average population density of Bangladesh, leaving its inhabitants no option to maintain physical distance from one another, let alone self-quarantine if symptoms appear. This single truth underscores the precarious reality for the Rohingya people when, not if, the coronavirus spreads into the camps. This evening, we will have a conversation between 2 scholars, a physician and a demographer, about the risk of a coronavirus outbreak in the Rohingya refugee camp. This part of the event will last for about 30 minutes. Then the scholars will answer questions from the audience for about 20 minutes. Please message me your question and we'll get to as many of them as possible. Lastly, Adam, our partner from the Burmese Task Force, will speak for a few minutes about upcoming projects they have for the Rohingya refugees. Before we go any further, I would like to share a photo slide with you to set the context for this event. These amazing photographs were taken by award-winning documentarians Gabriel Sassoni and Kam Assad. Now I would like to hand the stage over to the moderator, Dr. Shorful Halim, who is in the front line fighting against the coronavirus in Bangladesh.
Shorful Halim. I work as a medical officer in Goripur Upazila Health Complex in Bangladesh. I'm one of the frontline workers treating COVID-19 patients who can be either Bangladeshi or can even be a Rohingya. This webinar would help us to get a better idea about the risk and possible extent, impact of a COVID-19 outbreak in the Rohingya refugee camps. We'd also learn about possible measures that can be taken with challenges in their implementation. The COVID-19 pandemic is among the worst possible public health crises in recent memory. Almost 3 million people are infected, and over 200,000 people have already died from the disease. Today, we're delighted to host two distinguished scholars who will help us to better understand the risk of COVID-19 in Rohingya. Our first speaker is Dr. Ayesha Mahmud, a graduate of Carleton College and at Princeton University. Dr. Ayesha Mahmud is an assistant professor at University of California, Berkeley. Her research focuses on the relationships between human population changes, environmental factors, and infectious disease dynamics. Professor Mahmud has completed several extensive research projects on the health of Rohingya refugees, including a newly published work quantifying the success of measles vaccination campaigns in the Rohingya refugee camps. Our second speaker is Dr. Ruhul Abid. Dr. Ruhul Abid is an associate professor at Brown University Alpert Medical School and an executive faculty member of Brown Global Health Initiative. He received his MBBS from Dhaka Medical College, which is also my alma mater, and a PhD from Nagoya University, Japan. Dr. Abid founded the nonprofit Health and Education for All that promotes comprehensive health coverage for marginalized communities. Under his leadership, Health and Education for All has provided medical treatment for over 130,000 Rohingya refugees since 2017. Currently, he is training medics who are working in Kutupalong Rohingya refugee camps to combat the spread of COVID-19. So I'd like to welcome our honorable speakers. So Dr. Ruhul Abid and Ayesha Mahmud, welcome you to our today's webinar. So I will first ask the question to Dr. Ayesha Mahmud. So we already know that the COVID-19 is affecting the whole world, and the Rohingya refugees are at risk of developing this condition. If we consider the worst case scenario involving a fast spread of the virus in the camps, can you provide an estimate regarding the number or the percentage of the Rohingya population that might become infected in the next few months? So I would let Dr. Ayesha to answer that question.
Sure. Can you hear me?
Yeah, I can hear you.
Great. Thank you for the very kind introduction, and thank you to you and Tariqul for organizing this event and giving us a sort of platform for discussing this important issue. So to answer your question about the magnitude of the outbreak, I'm gonna refrain from sort of making any predictions about the number or the course of the outbreak and things like that, because there's so much uncertainty about these measures, right? So I think even in countries where we have relatively high testing and good data, things like the case fatality rate is very difficult to measure, right? So the case fatality rate it's a very simple measure. It's the number of deaths divided by the number of cases, right? But there's so much uncertainty about both the numerator and the denominator. So I just want to preface all of this with, there's so much we're still learning about the disease. And I think Dr. Abid can also talk about you know, there's just, from a medical perspective and a clinical perspective, there's just a lot we don't know. What we do know about the disease is that it is incredibly transmissible, and that once an outbreak starts, it grows exponentially, right? So what that means is that it can double really quickly. So what we've seen in many places is that a number that you've probably seen in the news, the basic reproduction number, R0, that a lot of disease models use. All this number tells you is how many, if you have one infected individual in a susceptible population, how many more individuals are they going to infect, right? So for COVID-19, that number is around 2.5 or 3. We've seen estimates as high as 3.5. It's very context dependent, right? So it really matters where you are. And so we know that these numbers are high. If a single person is infecting three people on average, and they may be infecting these people while they're not even showing symptoms. And so the onset of going from one person being infected to the next person being infected is really short. So what we've seen is this exponential growth of cases. And this has happened all over the world. And I think what we can, even though, you know, we can't project actual numbers without fully knowing everything about the disease, what we can say is, you know, an outbreak in the camps would probably spread extremely rapidly given the density. So things like R0 is very dependent on the density of the population. And Tariqul mentioned, you know, the Rohingya camps is more dense than Manhattan, and it's 40 times more dense than Dhaka. And we already think of Dhaka city as being an extremely dense population. So I think the challenge here is sort of, I think the numbers will be large no matter what. And it almost, in some sense, doesn't really matter how large that number is. I think we know it's going to grow exponentially if there is an outbreak. Right,
thank you. My next question would be to Dr. Abid. Like Dr. Ayesha already mentioned that camps are overcrowded, and this Rohingya people more vulnerable to experience a very serious outbreak. So can you please provide us some insight into why the Rohingyas are vulnerable apart from being overcrowded? Are there any other factors that make them more vulnerable to get this kind of outbreak in the camps?
Thank you. So thank you, the organizers, and thank you, Dr. Tariqul, for your question. And then, I think the main point that, as Dr. Ayesha Mahmud mentioned, that the overcrowding in the camp is like and Tariqul also, in his starting, he mentioned that it is like more than 100,000 people per square mile. So that's a hugely dense, crowded place. But that's just the density. But if we think of other perspective, as you, if you see that the population, the type of population, the demography, like they actually, since 1982, they have been deprived of any kind of systematic healthcare or any vaccination. So they didn't exist, their medical record, or they didn't exist in Myanmar health system. So 1982, they're like 40, 50 years. So they're without vaccination. That's why when they first came, 2017, 25th August, from that time, the latest exodus, they were before there. So they had initially polio, measles outbreak, and then finally they had diphtheria outbreak, which is like a rare, in Bangladesh is almost free of those diseases. So that shows us that they're not like the rest of the world's population, like vaccinated. They didn't have access to many basic human rights for 40, 50 years. So that's how they came. And then when we have 2 medical centers in Kutupalong and Balukhali. So as you mentioned, that we treated last 2.5 years, 130,000 patients. So we used an innovative model there. It's an electronic medical record, solar powered. So we have all the data of these patients and we can analyze. So we analyzed, and we will soon publish the data, that what we found there, that 7 to 8% of the population are hypertensive, above 18 years of age. They're 7 to 8% are hypertensive, 3 to 4% are diabetic, and there are malnutrition, 7%. And UNHCR has their data for 60 plus people, because you know that so these are the comorbidities that make them more vulnerable, right? So if they become sick or get infected with coronavirus, they will be more severely sick. The COVID-19 outcome, which we call in clinical terms, would be worse in these cases. If they're 50 plus, then, or 60 plus, and then hypertensive, diabetic, and then asthma, COPD, like obstructive pulmonary disease, and tuberculosis. So we have those data. So all combined together, I had a nice presentation slides which I shared. So that actually showed that it's 22% of the population is that vulnerable. And other components, just let me add briefly, that it's not only densely populated, it's also like there is no place for social distancing, because it's, you know, that makeshift camps, one after another. So each, like a small room, like 8 by 10 feet, they have maybe 6 people or 8 people living in there. So if, and another thing they use is a common toilet. 20 to 50 families are using common toilet. So as you know that it enters through mouth, nose, and eyes. And recent data shows that it excretes with stool. So using common toilet make them more vulnerable if it enters there. When it enters there, actually. So that's why there are many different factors. One is like historically they're persecuted, they're deprived, then malnutrition, then and also the treatment facilities are not enough. As you know, it's a refugee camp. So, and the common toilet and all those kind of living conditions make them really, really vulnerable to this. Thank you.
Okay, thank you. I would like to go on to discuss a part of population pyramid of the Rohingya refugees. As you know, that the Rohingya have a younger population when you compare that with other countries. So their population pyramid is kind of bottom heavy rather than being top heavy like those countries like Japan or other Western or developed countries. So does this pattern of population pyramid, which is bottom heavy, impact an outbreak, or can it be influenced by an outbreak? So what are the implications of the population pyramid regarding the coronavirus outbreak? Can you tell us something about that?
Sure. So I think there's sort of two aspects of it. So the first aspect, I think Dr. Abid already mentioned, there's some groups that are at a higher risk of having severe outcomes. And this is not just older people. People with comorbidities, as he mentioned, are at higher risk. And so I think we should, and this has come up not just in the context of the Rohingya camps, but in the context of many developing countries in general, where the prediction has been, well, you know, the population pyramid is very skewed towards the young population, so maybe the outcomes won't be as worse. But I think there's a lot of danger in making that sort of statement, because I think in a lot of these countries, and Dr. Ruhul Abid just pointed out all of the other factors that are at play. So just thinking that the population, you won't have severe outcomes because there's relatively fewer people over the age of 60, I think is sort of being complacent about the dangers of the outbreak. There's many comorbidities that are associated with a high case fatality rate and a high mortality rate, as well as a high rate of progression from mild symptoms to needing ventilation. So I think, yes, the Rohingya population pyramid is young, but I think that that is no reason to expect that the outcomes might not be as severe. I think the second aspect in which sort of demographers and disease modelers think about the age structure is through contact patterns, right? So we think of how fast the disease spread. Well, it matters who's having contact with whom. And even in very dense situations where everyone is very close to everyone, there's evidence from refugee camps that young people just have more contact because they're out and about, they're working age. And so in general, they have more contact than older age people. So in some ways, having a younger population means you're gonna have the disease spread a lot faster because younger people in general are having a lot more contact and transmitting the disease. So there's sort of two aspects to thinking about this age pyramid. Yeah. But I really wanna, I think the other thing that is really important in terms of thinking about the age pyramid, because the population is so young, and you know, the last time I was in the refugee camps, I went to a maternal clinic, like a BRAC field clinic, and we asked them how many babies are born, and they were like, oh, about 1 a day. That's just one clinic in, you know, one part of the camp. There's lots of babies being born. And so the real danger here, I think, is sort of essential health services getting stopped as a result of COVID. And then you're going to see all these other outbreaks. We've already seen measles. Dr. Abid mentioned diphtheria, which is a disease that's almost unheard of in that part of the world. And so I think the flip side of having this young age pyramid is if you stop these essential health services because of COVID, you're going to start seeing, we've already seen outbreaks of polio in parts of Africa because of this. And so I think there's that danger there as well.
Okay, so I think we have learned already that the Rohingyas are at very high risk of developing an outbreak, and if an outbreak happens, then it will be devastating to their livelihood. So I think global community and NGOs and local healthcare officials should be prompt in their action. So I would like to ask Dr. Ruhul Abid, can you describe the necessary measures that the global community, the NGOs, and the local healthcare officials should take so that the Rohingya camps are better prepared to prevent or limit such an outbreak? So what are the measures that they should take?
So that's a good question. That's a very important question, and the answer is very limited scope because it's a refugee camp in a developing country, number one, and then highly populated. And to begin with, the health structures, like we have many health posts, few primary healthcare centers. So primary healthcare center is where you have 4 or 5 beds and you can have inpatient, mostly outpatients. And there are few large hospital, like big hospital. One is Turkish hospital, one is Malaysian, and MSF has a kind of old hospital there. They built a couple of new hospitals. So altogether for 1.3 million people within the camp, you have 7 big hospitals. Those are like field hospitals. Hospital means not like what we see here or what we even see in Dhaka city. So those are like field hospitals. And so at this point, what we did, like all the organization, because government took one very effective measure that they kind of announced lockdown. So the whole camp, I think mid-March. No, like a couple of weeks ago, actually. Yeah, a couple of weeks ago, this April. So what this started doing is, like, they have multiple openings, like you can enter entry and exit points. So now they've closed all those and just secured one entry, one exit point, and banned all other activities, like other than essential activities, like health supplies, medical supplies, food, and that kind of things. Other than that, everything is for last 2 weeks is shut down. So one measure is that limit the exposure. Another, what we all together we did, we started actually announced the existing infrastructure for the healthcare system. We actually converted some of them to isolation center. So 18 isolation centers, but the bed numbers are very limited. Like almost 1 week ago, it was 72 isolation beds only for so many people. And then there are 257 additional beds. So now maybe around 300, 350 isolation centers. And as of like last week, I knew that there were no ventilators. So we're trying to get some ICU bed and ventilators. You know, like it's worldwide crisis. So the nearest hospital that has the ventilator, that's your Cox's Bazar Medical College. And so what we started, we did, so what other organizations so far did is we developed a triage system, like so that you can quickly find out the symptomatic patients and then isolate them in those isolation centers, and then take samples from there to Cox's Bazar Medical Center. There is just one testing center in Cox's Bazar Medical Center from IEDCR, who are in charge in Bangladesh. So they have performed around, I think so far 12 or 16 Rohingya suspected cases, but all came out negative. So far it's right now is that level. But I think all organization, what they can do is they started doing actually that informing the Rohingya people, because giving information is the first thing in a pandemic. You want to educate the people, you want to make them aware of the situation, what's there, because nobody has any idea, right? And these people are deprived and persecuted for so long, and they are in the refugee camps in a not very good situation for 2.5 years. So to give them information, so that's another obstacle we are facing there, that we don't have a text messaging kind of system there, and no internet. And so what we are doing with the help of government, that that CNG or TomTom kind of things, so they are announcing inside the camp. That's very effective actually. In Bangladesh villages also they're doing it. So they are announcing like what is corona, what it happens, what will happen. All the medical centers, we have our posters, leaflets, and there are some volunteers that are going home. So, and at this point, we proposed actually that, okay, since we cannot do like for all 1.3 million people, let's find out the people with comorbidities and people above 50 years age. And take those families and give them, say, bar soaps and a washing station inside the house, and cloth masks. So cloth masks are being built and are being made and distributed in the camps already. So these are some measures we are doing. But global community has to do a lot of things. I think they need to send fund not only to the Rohingya camps, because they need to send fund to the surrounding host communities also, because they are all integrated. At this point, we cannot just focus on Rohingya camp, because Bangladeshi community has to understand that if Rohingyas are not healthy or not safe, they will not remain safe. It will be there. And Rohingya community also needs to understand that the surrounding has to be like a disease-free, then they will be disease-free. So yeah, so a lot of things need to be done.
I think you have already answered my second question partially. Like I was going to ask you, what are the challenges that we would face when we have to tackle such a possible outbreak? So you have already mentioned some of the challenges like lack of adequate healthcare and difficult testing. So can you mention any other challenges, or can you tell us about the challenges that we as global community and the NGOs might face when they face such an outbreak?
When there is outbreak, that would be like main thing would be to contain it and isolate the people who are affected. And so like when someone is affected, what's happening in Dhaka in Bangladesh is like someone is affected, so they're going to the hospital, the rest of the household members are being quarantined. So here you can quarantine them but it's like they share the fence with one house to another, right? It's not a wall, actually, kind of a fence. So, or made of bamboo. So that will be really difficult. So I think what we need to do at this point is, as a preparation, we need to make a large isolation centers with treatment centers, devoted treatment centers, not the existing ones, build a new one. So government is taking some initiatives, but there should be from the global community and NGOs, international, there should be a lot of emphasis on building new isolation centers, at least isolating those patients who are already affected or clinically symptomatic. That would be the first step. And then more testing swab collection centers, because the sample collection centers are at this point not so many. So more, and train more people. And also these the community, the Rohingya, there should be Rohingya volunteers who should be trained, and they should be going to house, and in Rohingya language, they will show them like a video how to use a mask, how to wash hands, because there is no teletexting or like telemessaging or any audiovisual help for them, that we can just check our phone and find the information. They cannot do that. So there should be some intensive work there. And at this point, if there is some advocacy that for a limited time within the camp, we can open some communication channel between them, so that NGO and the government, Ministry of Health also, Bangladesh, can inform them that this is the thing you should do, like washing hand and all the preventive and hygiene measures.
Okay. I think you answered the question very well. And I would like to ask Dr. Ayesha Mahmud another question. Should there be a difference between the mitigation efforts taken in the refugee camps versus the ones that are already in place in metropolitan city like Dhaka? I think Dr. Abid has answered some part of it. I think, would you want to tell us something about that?
Yeah, I think Dr. Abid hit on all the sort of really crucial things that needs to happen. So more testing, isolation. It's, as he mentioned, it's just not possible to isolate families in their homes because they're using the same bathrooms, they're basically living right next to each other. I think the only other thing I would add to that, I think, is I think any effort to sort of contain the outbreak should really involve the community. And then there should be like an effort to make sure that there's no stigmatization of the disease. So if people aren't afraid to report symptoms. We've seen we're doing some work with BRAC in Bangladesh, and we've seen some evidence that people, they called and reported symptoms, but then when someone followed up, they sort of denied those symptoms because and it's totally understandable. They don't want to be stigmatized by their neighbors. They need to go out and earn a living. And I think that that could have very negative ramifications in the camp. So I think sort of involving the community, Dr. Abid mentioned disseminating information, making sure everyone is aware of what COVID is, and just making sure that doesn't become a hindrance to isolating cases and tracing cases and things like that.
Okay, so I would like to ask you another question. Would there be a difference in the transmission rate of COVID-19 in different weathers? Because I think we have a different weather, like we have a warm and humid weather, which is the monsoon, which is at the doorsteps right now. So, and after that, we will have a more cold weather. So would there be difference in the transmission rate of COVID-19 in different types of weather?
That's a good question. And I think that's a question that people are still trying to figure out. So there's some evidence, and this is, again, coming mostly from sort of temperate climates in the Western world, that beta coronaviruses, so these are in the same family of viruses, they transmit the common cold. We have a lot more data about this, so we can study them for long periods of time. And so studying these viruses suggests that there's increased transmission in dry seasons, but that's in the temperate world. So that doesn't necessarily translate to what might happen in the tropics, because in the tropics, for example, flu, which is also airborne and fomite transmitted, we see transmission increase in the humid monsoon season. And so I think it's very hard to tell exactly what might happen. I think the thing that we can say for sure is we don't know if climate is going to have an effect on transmission, but we do know that if climate does have an effect, that effect is likely to be really small compared to how fast the outbreak will spread in a completely susceptible population. So as long as you have a large number of vulnerable people, even if there's a climate effect, you're really not going to see that effect dampen the transmission. If an outbreak starts in the camps, regardless of the weather, it's going to spread. And I think unless there's some extraordinary effect of weather, which is very unlikely given what we know about these other beta coronaviruses, I think the climate effect, the speculation, at least in the Western countries now, is that the climate effect might come into play in the post-pandemic period. So once you've had these big outbreaks, the climate might affect when you see the next outbreak. So people are already talking about the second peak. But I think the first wave, because there's so many people who are susceptible to the disease, any climate effect will be negligible.
Yeah, right. I think you mentioned the point about the wave, and I think there has been a strong debate in US. I mean, the politicians are telling that the second wave is not coming, but Dr. Anthony Fauci and other specialists are telling that, yeah, in the fall, we will see another wave of coronavirus. I think you have mentioned it well in your answer. So before going to your Q&A session, I would like both of our esteemed scholars, would you want to add something to our discussion right now? Do you have something else to say or mention?
So may I say? So yeah, sure. I'd like to add that to that question that actually it's a dire necessity that the main focus would be to supply them with more information, the community, and more protective. Since we cannot give them space, we cannot give them the social distancing space, so we should give them more protective and hygiene and protective measures, like we are planning to package that. So like that kind of measures will be very important. And another is to break down the myths. There are many myths, like as you know, like in every place, even in Bangladesh, in villages, if you go that, oh, corona is, that person got corona, it's a sin, that person should be expelled from the village. So in Rohingya camp is, in addition to that kind of superstitions, I think there is another added distrust or mistrust between the authority and the Rohingya camps, because the Rohingya community, because they are like deprived and persecuted for like a decade. So, and then they're in the camp. So when we know like there are many myths, like sometimes they're asking to our doctors and our health workers. So if I say that I have a symptom, because you guys are asking for this cough, fever, and then whether exposure to some people. If I say that if there is any symptom, what will happen to me? I'll go to this isolation center and I'll be dead. They will kill me. So like, so this kind of thing. So I think those are very important to educate the community, to keep them informed, to make a good relationship with them. That's very important from all the partners. Thank you.
Okay, Dr. Ayesha, would you like to add something?
Yeah, I think I just want to iterate this point I made earlier, which I think we should focus on COVID, but we really shouldn't forget the other infectious diseases, because,
Right.
you know, the effect that, you know, I've studied measles a little bit in the camps, but the effect of any disease that breaks out in the camps can be devastating, and things that have a high fatality rate for children will be particularly devastating. So I think as we're thinking about COVID, we should also make sure we're thinking about these other diseases and taking measures and vaccinating.
Okay, I think we have had a very good discussion, and I think it would help not only me, but also other healthcare workers to get an idea of how to assess their risk and how to take steps. What are the steps that we should take? We have learned about those. I think it would help everybody. And thank you very much for bearing with me. Now I'd like to go to our Q&A session, and I would take some questions from our audience who have been patient and have been listening to us. So our first question is, would global telemedicine be an effective method to treat pandemics in the camps?
So may I answer that?
Yeah, sure. Go.
So yeah, so I think that that's a very, very good question. So this global telemedicine, because in many countries, like the private practice and the small clinics, for normal patients, they all went for telemedicine just to reduce exposure during this pandemic period. So in the camps, so the telemedicine may be helpful for the service providers, like the caregivers, say physicians, nurses in the Turkish hospital or Malaysian hospital, or our health centers like Haifa health centers in Kutupalong, Balukhali, and many other health centers. So for those patients, like physicians and nurses and healthcare providers, that will be very helpful to give them secondary opinion or guide them. But directly with the patients, there is no communication to them. Like, it's not possible to communicate with them given the existing situation, because they don't have Wi-Fi, they don't have a cell phone. So those are the limitations there. And another thing is what we did, it's not telemedicine. We recently, with the 3 of my students from Brown University, what we arranged in Bangladesh and through Haifa also, that we arranged a very nice training program for the care providers. It's called Training of the Trainer, and organized by Project Hope and Brown University. So this group actually worked in Ebola pandemic in Liberia in 2014 and became Person of the Year. So they actually provided 75 participants in Bangladesh, BSMMU, DMCH, like Dhaka Medical, and also in the Rohingya camps, Haifa and other DGHS government doctors, then some from WHO, Save the Children. So that kind of training we organized by that. So it's kind of part of not global telemedicine, but it was part of a global kind of a tele-training.
Yeah.
So it will be helpful.
Right.
Short answer is yes for the providers.
Yeah, okay, thank you for your answer. Dr. Ayesha, would you want to comment on that?
I think Dr. Abid has covered all, and he knows much more about this than I do.
Yeah, I think Tariqul is, please.
So, asking Dr. Mahmud is there's 2 forms of immunity. One, you have hard immunity, which, you know, if enough people gets the infection, then the disease can spread. And the second type of immunity is just getting vaccination. So he was wondering, since they talked a lot about there's a lot of going to be a very high rate of infection if it do occur, is there any mathematical modeling that's been done about getting hard immunity before the vaccine comes in? Because the vaccine, they says, like 18 months or so, like that, you know? So he was wondering.
That's a good question. And I mean, I'm sure everyone has seen sort of the whole kerfuffle with the UK and the herd immunity strategy.
Right.
I think in the Rohingya camps, unless there's some sort of, you know, massive effort to stop the outbreak if it starts, herd immunity might just happen without us being able to do anything, sadly. I think the danger of herd immunity is normally when we talk about herd immunity, we talk about it in the context of having a vaccine, right? So this concept of herd immunity is how many people do you need to vaccinate in a population? You don't need to vaccinate 100%. So for measles, which is a very transmissible disease, so the R naught for measles is 18, which is much higher than something like COVID. The herd immunity threshold is 90%. So you need to vaccinate at least 90% of the population in the camps to make sure that enough people are immune and it doesn't spread. So to talk about herd immunity not in the context of vaccination, to use it as a strategy for mitigation, I think is a dangerous game. And I think the UK sort of realized that and backtracked. I think the reality is that if an outbreak spreads through the camp, you might reach the herd immunity threshold anyways, and then the outbreak would die off because there were not enough susceptible people and the R naught drops below 1. I think the sort of scary part of that is you have, as Dr. Abid mentioned, there's so many people with comorbidities, and in those groups, you're expecting a higher mortality rate and a higher rate of needing ventilators. If you allow this outbreak to play out, the healthcare system is already overwhelmed in the Rohingya camps. It will absolutely be overwhelmed if that happens.
Okay. So I would go on to ask another question. I think this is the longer question from Steve Ross. So please bear with me. I'm wondering if the speakers are familiar with the study from the Johns Hopkins School of Public Health, which estimated a high infection scenario of 540,000 infections in Kutupalong and 2,000 deaths within a year. If so, I'm wondering if they could comment on this. It seems to me that the mortality rate is very optimistic given the population density, pre-existing conditions, and access to hygiene, etc. So did I get the question right?
Yes. So actually, let me take on that one. So I was trying to share the screen because I have that paper's data here.
Okay.
Can you enable me to share the screen?
Circle, let me just message him.
Okay. So yeah, so the short answer is yes. I read that paper and my students also analyzed that paper, and we have a nice curve here. So yes, so it shows that there will be very high infection rate in the camp, and their conservative estimate is 2,000 patient, 2,000 death in the camp if it happens. But what we think is, if it happens, it probably will be more than that, because there will be, as Dr. Ayesha Mahmud mentioned, that there will be other patients who will not receive treatments because of this COVID-19, like mass infection, and like a lot of people are getting sick and in a confined space. So there would be much more death, I think, than 2,000 if it's unchecked infection is there. So that model, I think that it's kind of a conservative model for death, what Johns Hopkins published.
Okay, so Tariqul, can you tell us how Dr. Ruhul Abid can share his screen?
You could just hit share screen, and we just fixed his setting. So you could just hit share screen and we'll be able to see his screen.
Okay, yeah. So I think, yeah, this was the curve that we generated from that infection rate. You can see that.
Yeah, we can see that, right?
Yeah, so this is the paper actually we analyzed, and they showed different curves there, as Mr. Steve Ross mentioned, that 71% of the population would be within 1 year it will be affected. It's a high rate. You can see the peak, the high rate of infection. They have moderate rate of transmission, and then like a low transmission rate. And as also Dr. Ayesha Mahmud mentioned before, that we had this transmission rate, the R naught, that R naught is 3.5 to 5. It will be like high R naught there because for the population density, because if you think of the diphtheria outbreak was like that. So yes, so this paper actually shows, and then finally it shows the death 3.6%, and here is that 2,109 total deaths. So yeah, we analyzed that, and then, but our point is like it would be much more than that. That's our prediction if it happens because of the other factors involved.
Okay.
Yes.
Okay. Thank you for a great answer, great demonstration of this. We hope that doesn't happen.
Yes.
Okay. So my next question is also from Mr. Steve Ross, which is, could the speakers touch upon vulnerability of the Bangladeshi community which lives in and around Cox's Bazar?
Ayesha would like to take that? Or?
Sure. I think so. I think there's a few sort of differences in the communities in terms of the history of healthcare received, right? So Dr. Abid mentioned this. The Rohingya camps, they haven't had vaccinations ever in a really long time until they arrived in Bangladesh. When the diphtheria outbreak broke out in the camps, it didn't actually spread to the host community as much. There was a few cases, I think, but it was mostly contained, and that's because Bangladesh has done a really great job historically of keeping vaccination rates high. But I think that in terms of this current outbreak and the current crisis, it's really important, and I think Dr. Abid already talked about this, it's important to have sort of a coordinated response, because you can't really separate the camp. Even if you have it locked down, you need to take the host community into account, and what's happening in the nearby areas is going to affect the camps. There's not really a way to sort of separate out these two populations, and there's vulnerabilities in all over Bangladesh, and there's people with comorbidities not just in the camps but in the host communities as well. And so the host community is not protected in any way from the negative impact of COVID-19. And I think a coordinated response where both host community members are involved and the Rohingya community members are involved will be what's needed.
Yeah, right. Thank you for a great answer. I think, yeah, cooperation is essential. And I think there is also an important point about cooperation between the NGOs and the government health services. And my next question is regarding that. So Mr. Adam has a question, which is, are local NGOs able to coordinate with Bangladeshi medical authorities? And what needs to QC, is there sufficient PPE for hospitals, and what can be done to restore internet service in the camps? So I think there are multiple questions. So first, are the NGOs able to coordinate with the government? And next, is there sufficient PPE in the hospital? And then I think there is also another question: what can be done to restore internet service? So there are actually three questions.
Yeah. So let me answer that. So at this point. So the coordination is very good with the government, because the whole Rohingya camp healthcare system runs through a cell, which is called coordination cell. It's an inter-service kind of it's a DG Health, then the civil surgeon, local UHFPO, as you know, the sub-district chief, and all the organizations, WHO, UNHCR, IOM, you just name all the organizations, BRAC, Haifa, our organization, Haifa. So all together, so they have different focus, but it's all coordinated, and we have the joint response plan. So we are also planning a joint response submission for this COVID-19 preparation. We already did like a preliminary. We're finalizing this 30th of this month. So yes, it's a very coordinated effort there, and I think that's why it's working so well. And as also Dr. Ayesha Mahmud mentioned, that like the measles and polio and all those things were prevented, because so far, I think very successfully, government, UN organization, and other NGOs at least prevented. I say that, I mean, many places, that at least 3 to 4 epidemics inside the camp so far in last 2.5 years. So, but at this point, we need to do more. And PPE, no, there is not enough PPE, because my team, I have like a 22-member team altogether, like in Cox's Bazar and other places, the supporting teams. So we provided, I had to get our own PPE. from Dhaka, and from fortunately we took almost 3 to 4 weeks, but we have a recent shipment from outside the country. So we got some N95 mask and all those PPE. So we are providing, each organization is trying to provide, but it's not enough. There should be a coordinated effort to give PPE to everyone. There is, but as in other places, there is a shortage. And for internet, I think it's a bigger question. It's a very sensitive question, and it has to be addressed by the government of Bangladesh.
Okay, thank you for a great answer. I think you have checked all the points. My next question is from Tahmid Jawad. In regards to occupational health and hygiene, what are some potential policies that could be implemented by the Bangladeshi government to help prevent the rapid spread of COVID-19 and other diseases? I think we have covered it in our primary discussion, but would you like to comment on that? So what are the things that government should do in regards to occupational health and hygiene and the potential policies to prevent?
I think Dr. Abid probably has already covered almost all of these points, which is dissemination of information, dispel myths, and distribution of sort of masks and things that allow people to protect themselves. And really in a country like Bangladesh, not just in the camps, in Bangladesh in general, you can't, the cost of stopping the economy is so high, you can't really expect people to not go to work and to shut down the economy, right? So what works, is working in California. It's not a solution that's going to work for Bangladesh, right? And so and people will need to go back to work. And so trying to think of ways to enable them to do so safely is really important. And I think information is extremely crucial. Dispelling myths, making sure people are stigmatized, that people feel okay to seek care and be willing to isolate and, not sort of be stigmatized by the society. Protective equipment, masks, and things like that. These are all things I think that should be done. And Dr. Abid might have more things to add, I think.
Yeah, Dr. Abid, do you want to comment on this question?
No, I think you covered it well. So I think, yeah, those are the main things we should do.
Okay, thank you. I think we have a very interesting question next up. This is from Rashid, and his question is, will COVID-19 become a seasonal virus like the flu? And he also added another question behind it. With a new, will be a new vaccine needed for a new strain each year like the flu? So if it's going to be like flu, and do you have to have new vaccines every year?
I can talk a bit. I won't touch the vaccine question. I think Dr. Abid, who actually knows biology, will probably be able to answer that better. I think in terms of the climate, I think, again, I think it's an open question, and there's a lot of speculation that it might. There's a new sort of paper out from folks at Princeton trying to look at this, and the idea is if it behaves similar to other sort of viruses in the same family, so the beta coronaviruses, we might expect to see seasonal outbreaks. The issue with that is what's really going to drive that is how long immunity lasts, and that's an open question. I don't think we have a good sense of that, right? So if an immunity lasts 5 years, the outbreak dynamics and the waves you get are going to look very different than if the immunity lasts for a few months, right? So for the common cold, many of which are caused by beta coronaviruses, immunity doesn't last very long, which is why you see these regular outbreaks. So I think that's an open question that people are actively trying to figure out.
I think that's a $1 billion or $1 trillion question. So do you get immune after getting infected?
Right.
And what are the chances of getting reinfected, and part of it, and how to measure the immunity? And
exactly.
People are scrambling to put up some tests to measure the immunity. So do you want to comment on, Dr. Abid, do you want to comment on the vaccine development? So what are the things that are going on there? We don't know much about the vaccine.
So yeah, so the vaccine development is a very interesting thing. So it's at this point, so at first the previous caller's question that whether it would be like immunity, how is immunity, and whether there will be different strains. So it's too early. In brief, it's as Dr. Ayesha Mahmud pointed out, that it's too early to talk on those things. So similarly, like vaccine. So like there are several trials going on vaccine, as you know, that RNA, DNA. So like a Bill Gates group, and then some from the England, Germany, US. There are many different groups have DNA, RNA, different kind of vaccine trials. So those vaccine trials will take time. So, and then those vaccine trials will also depend on the production of antibody, induction of antibody by this virus, and the stability of that antibody induced by this virus. So the vaccine trials would be also dependent on the nature, how the antigen and antibody is reacting in human body. So to answer that, it's like too early for any vaccine trial. So any result would be from 12 to 18 months to get a preliminary idea that it's working or not. And I think earliest successful vaccine was like 6 to 8 years. That was the previous history.
Oh, that's
so
a long time.
Right. So if it's like, even if it's earliest, because this is a different scenario. We're in 21st century, and it took only 10 days to sequence the coronavirus genome, and they published it online, and then the US labs picked it up, and they started like ordering the virus particles, and then they started doing experiment with that. So this is a different ball game at this point. So we are like a very fast-paced, state-of-the-art everything. So that's why we started even the vaccine trial. This is the quickest vaccine trial we have ever did. So let's be hopeful. Maybe 18 months we'll get some answer, but not before that.
Yeah, we should say prayers every day to get the vaccine as soon as possible. I think we have had a very fantastic discussion regarding many aspects of the viral outbreak in the Rohingya refugee camps, and we also got the idea about the virus itself and the season, and also what are the things that the global communities, the NGOs, and the government should do, and what's really happening. We're happy that still there is no patients detected in the Rohingya camps, but as Dr. Ayesha mentioned in her answer, that there are often asymptomatic spread, which is very dangerous, because we might not even know what the carriers. So I think I cannot thank enough to our respected speakers to provide us with their valuable insights, and I think I have learned a lot actually, and we will be able to beat that virus someday, probably, with your insights and your work. I think you will be working very closely with the Rohingya communities. I wish you all the best, and I think you will be able to contain the coronavirus spread in the Rohingya refugee camps. So I think I have to only say that stay safe, because I think Dr. Abid is in a vulnerable group, because he's but senior. But I think young people are also vulnerable. So my wish is to stay safe, and Dr. Ayesha, stay safe. That's the only thing I can wish you for now. And thank you very much for joining us in this discussion. Thank you.
Thank you.
Thank you.
Thank you.
We're not done yet, guys. Thank you, first of all, everyone, for joining. We just have Adam, who's going to say, who's sponsoring our essay contest next year, for this year. He wants to say a few things about some of the work that's going to be coming up with Rohingya refugees that they're doing. And so, Adam will speak for a few minutes, and then, I'll say a little bit of last thing, and then, first of all, the discussion was amazing.
Yes, thank you all very much. That was extremely thoughtful and well-informed. And I also admire the approach of Rise for Rohingya. We're happy to partner on the essay contest. I live in Queens, New York, and of course, we're an epicenter of this terrible virus. There's about 20,000 dead in New York City. Many Pakistani and Bangladeshi families have lost members. I work a lot with the Muslim community here. It's very traumatizing not to be able to do funerals, very difficult to do Ramadan right now. So in that context, it's difficult to imagine that the crowded refugee camps will escape this terrible scourge. But I really hope so, and with your efforts. With the Burma Task Force, we were founded in 2012 to address human rights abuses in Burma, and then the genocide and the mass displacement took place. we focus on refugees and displaced people and persecuted minorities, including in places like India, where we see xenophobia increasing because of COVID-19. We also had a talk today with a Rohingya leader named Sharifa Shakira, who is director of Rohingya Women's Developmental Network in Malaysia, talking about the same terrible impact of COVID creating a reaction against the Rohingya refugees living in Malaysia. And they have been accepted there for years, and now suddenly there are anti-Rohingya movements spreading. So we see that, unfortunately, COVID-19 can have a social impact. We hope that in Bangladesh, we won't see this. We know that there's tensions with the host community, and we thank you all for working to build those bridges. The monsoon is coming. How will that affect this community in the midst of a possible outbreak? The issue of allowing ships in, all of these things obviously will demand attention. So human rights is a human rights protection. It goes along with humanitarian work. It's complementary. And so we as a human rights organization at burmataskforce.org and also look us up on Facebook. We're very active in Congress and at the UN. We have a May 8th Human Rights and Ramadan conference coming up, which you can find on our website. They all include action steps, and action steps meaning, how to reach out to Congress, how to reach out to the UN, how to reach out to agencies working on the ground. For example, a WHO employee was just killed in Burma as he delivered COVID testing samples. So there are other things that we ask people to act on every week. So if people want to take some action to address root causes of this terrible situation, until we address those root causes, the refugees will still be in the camps and facing the peril of their situation. So again, thank you very much for all the medical workers and experts who spoke today. And I hope people will check out our website and get involved. Thank you.
Thank you, Adam. Thank you, Adam. Thank you, Adam, for supporting us. And again, thanks to all the speakers. And the last idea that I want to leave everyone with, Winston Churchill once said, if you're a stateless population, you are a global citizen. So that pretty much says that the Rohingya people are not the citizen of a country, but they're a global citizen. So there's an obligation for all of us, even if we're suffering in New York, or if we're not suffering in another country, to get involved with this issue, because as a global citizen, we need to get involved with this. And John just wants me to leave with this one idea, is that in his new books, he talks about there's an allergy to having nuanced conversation that most people wouldn't have. And he thought this discussion was trying to combat that idea, that having conversation at a very deep level, and also having conversation that some people may not want to have. So again, I want to thank everybody for participating. I want to thank my team member for painstakingly coming up with the questions and emailing everyone and making this possible. And I want to thank again all the speakers for their time. And I hope everybody stays safe in the upcoming months. And we'll get together and do greater, more good work for the Rohingya in the future. Thank you, everyone.